So good evening everyone. Today let us understand what is dysmenorrhea. Primarily dysmenorrhea means painful menstruation. So there are a lot of classifications for this dysmenorrhea like primary dysmenorrhea and secondary dysmenorrhea. So let us understand first the pathophysiology and then we will move to the different classifications. So painful menstruation is the problem here. So who is causing this pain? So when we look at this, this is uterus. These are the uterine musculature. Here, very important feature of the uterine musculature is these muscles are arranged in a crisscross pattern. They are like a sieve. Whenever a blood vessel is passing through it and there is a contraction, they will lock these blood vessels and they prevent the blood flow to the uterine muscle. This leads to the hypoxia. But normally, in every woman, this is the same mechanism. What happens in people who have this dysmenorrhea? Like they have excessive pain during menstruation. Their myometrium, which was supposed to contract normally, now it is hyperreactive. So, who is causing this hyperreactivity to this myometrium? So, let us understand the three different pathophysiologies which are leading to the problem here. There are three layers in the uterus. One is endometrium, the second layer is the myometrium, and the third and outermost layer is the serosa. This myometrium is divided into two layers. One is subendometrial layer, which is just above the endometrium, subendometrial myometrium. This is called, and the second layer is the outer layer of the myometrium. This subendometrial layer, this is also called as the junctional zone. There is hyperreactivity in this junctional zone, means the muscle which was supposed to contract at regular intervals, sometimes it is contracting a lesser and sometimes it is contracting more than what it is required, which is leading to the myometrial hypoxia and thus angina. In which conditions do this myometrial dysrhythmia occurs is in cases of endometriosis and in cases of adenomyosis and also in cases of primary dysmenorrhea. That means without any problems as such, some people have problem with this junctional zone. And the second cause is you're seeing some circular fibers over here. This is nothing but cervix. This is external os and this is internal os. There is problem around this circular fibers. Even these are contracting too much, which is leading to pain. There is a supply for this. That is autonomic nervous system, which is a supply for this circular muscle fibers. And there's imbalance in this autonomic nervous system so that it is contracting more than what it is required. Thus, some people who get relief from this pain following the delivery because the cervix is completely dilated, fully dilated, and there is some destruction in the circular muscle fibers, and thus there is relief of pain following the delivery. And the third and the very important cause is the progesterone withdrawal. In the ovulatory cycles, means the ovulation occurs at the 14th day of the menstrual cycle and there is release of progesterone after that, and this progesterone peaks and at one point of time the withdrawal occurs, and thus there is shedding of the endometrium. As this progesterone withdrawal occurs, along with the shedding of the endometrium, there is release of these prostaglandins. These prostaglandins are made from the arachidonic acid, which is a component of the cell membrane. When these cells are destroyed, this arachidonic acid is released and thus production of this prostaglandin F2 and prostaglandin E2. Among this prostaglandin F2 alpha is a strong vasoconstrictor. It goes to the uterine musculature and it causes strong contraction, which leads to the myometrial hypoxia and causes myometrial angina and thus pain during the menstrual cycle. So here is the pathophysiology of the dysmenorrhea. Further, we will understand what are the clinical features and treatment of the dysmenorrhea. So now let us come to the classifications of dysmenorrhea. There are two types of dysmenorrhea. One is primary dysmenorrhea and the second one is a secondary dysmenorrhea. Our primary dysmenorrhea is nothing but the dysmenorrhea, the pain causing just in absence of any other problem like any other pelvic pathology. Usually the adolescent women, adolescent girls who are very sensitive to the pain do experience this primary dysmenorrhea. Risk factors are young and usually occurs in the ovulatory cycles. As I told you, there is progesterone withdrawal which is needed to release these prostaglandins. Thus, it occurs in the ovulatory cycles. And it is cured following pregnancy and following delivery, as there are the circular muscle fibers around the isthmus of the cervix are destroyed following pregnancy and during the delivery. We understood the pathophysiology properly. And coming to the clinical features. This starts just during the menstruation as the endometrium sheds and the prostaglandins are released during the menstruation, and it does not persist beyond the 48 hours. But as in case of secondary dysmenorrhea, the pain mechanism is entirely different, where there is some other pelvic pathology which is occurring, the pain which persists even after the cycle and before the cycle. And the patient might experience nausea, vomiting, fatigue because she's having a lot of pain, and these are the reactionary things which are occurring. And she might have sweating, and she might feel cold, and occasionally she might faint. When you do any examination, when you do pelvic examination, you cannot find anything. You cannot find any fibroid, adenomyosis, or etc. There are a lot of other pelvic pathologies which we will discuss in secondary dysmenorrhea, and scan findings are negative. So, coming to the treatment, the first part is a psychotherapy. You reassure the patient and calm down her, tell that it is not abnormal. And many of these people experience pain during menstruation, and she has to have that capacity to hold the pain. Secondary thing, what you can do is you can give this prostaglandin synthetase inhibitors. As you can see, this phospholipid will give rise to arachidonic acid. Arachidonic acid is now metabolized by cyclooxygenase, which causes release of this prostaglandins, prostacyclins, and thromboxane A2. This cyclooxygenase enzyme can be inhibited by some of the drugs like NSAIDs, example ibuprofen, mefenamic acid. Thus, it will decrease the production of the prostaglandins. So the prostaglandin synthetase inhibitors, they work on this COX enzyme and they inhibit the production of the prostaglandins. Examples are mefenamic acid and propionic acid derivatives. Mefenamic acid is nothing but they belong to group called phenmates. You can give 500 mg TID up till the cycles like 2 to 3 days. And also you can give propionic acid derivatives like ibuprofen 400 mg TID for 2 to 3 days. So this can be tried for 3 to 6 cycles. And if it is not working out, then you have to shift to some other drugs like ocipils. Contraindications you must know are allergy to the aspirin, and if they have gastric ulceration and history of asthma. Ocipils. Ocipils. How? First of all, we have to know the mechanism of action of ocipils. These ocipils prevent the ovulation. They have their own content of estrogen and progesterone, which will negatively inhibit the GnRH pulse and thus release of FSH and LH, and there is no ovulatory cycles. So people who are wanting the contraception, for them, as there is no ovulation, there is no progesterone, as there is no ovulation because of this ocipils, this is a best choice for the people who are wanting contraception. And people who are also having heavy periods, as these ocipils are negatively inhibiting the cycle HPO axis. Now there is no normal cycles occurring because of the hormonal imbalance occurring in the body. This occipils will control the cycles now, and for 21 days you can give this occipils and stop the occipils where the patient will have normal bleeding, and you can continue this occipils for 2 to 3 cycles. Next is when the patient is unresponsive, or if she has any contraindications to prostaglandins, you can give occipils. And we always tell that continuous regimen is better than better than the cyclic. What is continuous regimen? Continuous regimen is the patient is given continuously 84 days and then you stop for a while. Cyclic is the patient is given 21 days of the cycle and then stop for 7 days, then 21 days, stop for 7 days, again 21 days and then stop for 7 days. This is for 3 to 6 cycles. Continuous is continuously for 3 cycles, like for 84 days, and then you stop for a while. So, management protocol for primary dysmenorrhea. This is a summary. First, you reassure the patient, you give analgesics, and you encourage her to do normal activities. And also, you can also give some antispasmodic drugs. If it fails, then if there are no contraindication to prostaglandin synthetase inhibitors, and if the patient is wanting pregnancy and the patient has a contraindication to pill, either of them, you can give prostaglandin synthetase inhibitors. But if there is no contraindication to pills and if she wants contraception and patient in the presence of contraindications to prostaglandin synthetase inhibitors, you can give them OC pills. If you give OC pills and you try for 3 to 6 cycles, and if there are no contraindications for either, you can shift over to the other drug. So 6 cycles you try OC pills, and then 6 cycles you try prostaglandin synthetic inhibitors, and then if it fails, you can go for further management like transcutaneous electrical nerve stimulation and LUNA, that is lumbar sacral neurectomy, and etc. So when to do scan? Should we directly can send back this patient to a home? No. If the patient is having severe dysmenorrhea, like she's coming to the hospital in the night, she's telling her it is unbearable pain, then you have to do a scan, which the patient's activities are clearly inhibited. She's not going to school, she's not going to work. Then you have to think that there is some other cause rather than dysmenorrhea, and you have to treat it. And whatever treatment you're giving, like analgesic, there is a poor effect on it. So, what are the differential diagnoses that you have to keep in your mind? One is the first most important cause of dysmenorrhea is endometriosis. Second is pelvic inflammatory disease. Third is adenomyosis. And fourth is congenital anomalies of the uterus. Fifth is pelvic congestion syndrome. Sixth may be miscarriage ectopic, which might be or which will be associated with bleeding. So, what is this endometriosis? Here, the menstrual blood, which was supposed to flow outside the cavity, now it has spilled inside the pelvis, and it is happening so regularly. So every time the endometrium is now grown in the pelvis over there, and every time she starts bleeding, the endometrial deposits in the pelvis they starts bleeding by themselves. Pelvic inflammatory disease. In this pelvic inflammatory disease, there is inflammation and there is adhesions which are causing pain, which is occurring during the menstruation. Adenomyosis. Adenomyosis, there is a growth of the endometrium into the myometrium, and this causes junctional zone dysrhythmia, and it causes pain in cases of adenomyosis. In case of congenital anomalies of the uterus, there might be a non-communicating horn inside which the patient will have bleeding inside the non-communicating horn, and thus the patient will have congenital anomalies. In the congenital anomalies, the blood collected inside the cavity of the non-communicating horn might cause pain. Miscarriages. In cases of ectopics and miscarriages, it will be associated with pain, but the patient will have associated bleeding along with that, and she has a period of amenorrhea previously to that you have to keep in the mind.